Good morning and welcome to HPI 2020 Day 3. And today we have a strong investment theme for you, don't we, Max?
We do indeed. It's a fascinating time with so much dry powder around and yet also so much uncertainty.
This morning we're very excited to have an actual real-life guest here in our
actual
virtual studio. We're very excited about that, aren't we?
We are very excited about that. Very excited. Very excited. Yes, we have Martin Henrichs, the Managing Director and Head of Healthcare EMEA at UBS, and he's also going to be leading our Investing in Europe panel later. Before that, I'll be talking to Dr. Nick West, who's the Chief Medical Officer at Abbott Vascular, about how he sees personalised care and the way it's set to transform healthcare. So Nick's a really interesting guy. Before joining Abbott, he was a consultant cardiologist at the Royal Papworth, which is probably the most prestigious cardiology centre in the UK. And he's also was involved in as a CMO in a startup, so he's seen many angles of life. And he's giving his personal view based on his experience as both a physician provider and now at a large medtech group.
Okay, great.
So
let's take a look at what Nick has to say. Thanks very much.
Thank you very much, Harry. Excellent. Good. Okay. Yep. Okay. Yep. Okay. Hi, Nick.
Good morning, Max. How are you?
Hello. Hi. Can I hear you, Nick? I think I can.
I hope so. I can hear you.
I can hear Nick, but not very loudly. Hold on a second, Nick. I'm just going to adjust my speaker so that I can have a good conversation with you. There we go. Say something, Nick.
Can you hear me now?
Nope, I can't hear you at all now.
Oh.
Whoa.
I'm definitely talking.
Yeah? Okay, fine. Okay.
Nick looks very excited to be there, though, doesn't he?
He looks very excited to be here, and he can clearly hear you, which is good, isn't it?
He is very happy.
He is very happy to be here.
Can I do it in sign language?
In sign language, yes. Well, I heard that, and then I don't know.
Very good. Unfortunately, my Macathon is not very good, so I'm not sure I would sustain an interview in sign language.
All right, okay. I have no sign language either. You could write your answers.
We could try that.
We could indeed. Well, we seem to be, I don't know, are we okay, guys, or not?
That's fine.
It's fine. Okay, it's fine. We're due to start, are we? Okay, good. Fine. Okay, thanks for letting me know. Okay, hi, Nick. Hello. Well, welcome, and thanks very much for joining us today.
Thank you. It's a pleasure to be on. I hope you can hear me now.
Yes, I can. So I was, so it's just very interesting, I think, to talk to somebody who's been a physician and then joined, I guess, big med tech, and I know, for you, personalised medicine is really something which is very dear to your heart, isn't it?
Yeah, and I think it's fair to say that personalised healthcare has always been something that we've spoken about in medicine. And I think that people have always, I won't say laboured under the misapprehension, but they've always thought they were giving their patients a personalised experience. But in truth, the problem is that with increasing reliance on guidelines, which tend to be sort of patient-specific agnostic, if you like, if I can use that term, people get all lumped into the same bucket, and every patient is different. Every patient has different comorbidities, different experiences in the past, different genetics, different medications they're taking. And of course, that means that one patient with a heart attack is very different to another patient with a heart attack and another one. And to think that we can simply follow a recipe for a one-size-fits-all solution, really, it's not intuitive. And although guidelines are great for increasing the uptake of some of these evidence-based techniques, it really is a one-size-fits-all. So it's the equivalent of buying a suit from a shop rather than having one tailor-made for you.
Yes, yes. So, and was it the case that when you were working as a cardiologist, that actually the pathways became more and more rigid, and that I guess at one level you were moving away from a situation where you were an expert who at some level could have a hunch about somebody or could look at the data and could towards something which was much more prescribed in a way.
No, I mean, I think that's fair, but I think, not to do down guidelines. I mean, the whole purpose of guidelines is that it removes some of the variability in practice, so that at least people are doing the same sort of things. But you are right; they become a little bit restrictive. And if we're going to really truly transform vascular care, which obviously is my interest now, it's always been my interest has always been in cardiology care, but vascular care as part of a large med tech. We've really got to look at ways that we can try and address this. And rather than me say this is something that I've stumbled across in the last several months, I was looking back through my LinkedIn posts, and as you kindly mentioned, I was CMO of a small Cambridge-based startup for nearly 10 years, and my very first LinkedIn post was about personalized healthcare with regard to that technology. So this is a drum that I've been banging for a little while now.
So what does this mean from an Abbott perspective? I mean, I guess it's stents is the kind of main business, isn't it? And so you're going from selling a product to doing something very different, basically.
Yeah, and I think this is key. You've hit the nail on the head, as you say. You said stents is the business. For Abbott Vascular, you're absolutely right. It's all been about the technologies that cardiologists and endovascular interventionists use during procedures where they will non-invasively or minimally invasively, if you like, replumb bits of the circulation. But I would like to think that this is a big change of mindset, or it needs to be a change of mindset. And I hope that we're undergoing it in a timely fashion. We need really to move away from the concept of a device. The device takes up such a small snapshot of the patient's, if you like, disease career. And we're so focused on that moment that the patient is in the catheterization lab, the operating theatre, whatever you wish to refer to it as. We're so focused on that moment when the stent goes in. But of course, the patient existed for 30, 40, 50, 60 years before that. And they may have had symptoms for, upwards of 5 years before that. And of course, one hopes they're going to survive many years after the intervention. So it's been a process of really trying to think how we can change what we offer from a device to considering actually a therapy for forms of vascular disease, and then to go on really to provide a solution. And this is all part of trying to look at the entire patient holistically, consider the pathway, the continuum, and think how we can intervene meaningfully on that to improve things for patients. And I'm going to say patients again, because as a physician, or as a recently ex-physician, the patient has to be the center of everything. And if we start from that premise, we've got to do things for the patient, not necessarily primarily for the doctor or even for the hospital. But if we make it better for the patient, it will make things better for the physician or the surgeon, because the patient won't be coming back as often. They won't have problems with their procedure. They won't keep coming back with more symptoms.
Yes.
And in turn, then, of course, that benefits healthcare systems. There's less of a burden for these patients coming back, if you like, as frequent flyers. So I think it's a mindset change, and we are trying to digitally transform ourselves internally. And in parallel, we've undertaken this very large external survey, which we published as a white paper in the summer, called Beyond Intervention, which addresses this exact issue, considering the whole patient and really drilling down onto how data and technology can improve our interactions.
Yes, so it's a really massive journey, actually, isn't it? I mean, it changes everything, I imagine. I mean, in Abbott at the moment, you've got islands on the journey. You can see different places where you are doing a lot of this work, aren't you? And that's producing results. But it's also now about bringing in the big data and the AI to make it much more precise, isn't it? That's another step in the journey as well, isn't it?
No, I think that's right, and I think you've highlighted another parallel there. I mean, at the present, and our Beyond Intervention survey highlighted this fact that even before the COVID-19 pandemic, which I think has highlighted some of these matters, healthcare systems are incredibly fragmented. Not only do the things like the patient records not join up, so physicians or healthcare providers at different parts of this patient journey may not have access to all the bits of information, investigations from before, but also the way that we interact with patients is very piecemeal. You'll see a patient when they come in with a heart attack. You might see them when they have their follow-up appointment. You may not see them again. Of course, months and years may pass between some of those interactions. So it's very staccato. And I think that if we look at how medtech in general behaves and we look at that patient pathway, our interaction is very fragmented. We'll have tools that address certain bits of the journey without really a thought as to how they can join up and really create an offering that creates a solution for vascular disease, if that makes sense.
Yes, no, it does. It does. So that means starting quite early on the prevention route, or identifying people who are likely to have problems with predictive analytics.
That's fascinating. I mean, you mentioned AI before. Big data is something that it's a very 21st century buzz phrase, and I have to be careful when I use phrases like big data and artificial intelligence, because they are used a lot by people when they want to look futuristic, and we just trot these phrases out and say, this is what we need. But I think in the vascular field and in many medical fields, one can really see the value of these. And there have been examples where these machine learning algorithms have brought meaningful change. I can think of, there was a Microsoft project on sudden infant death syndrome, where they were able to synthesize data from publications, from primary research, from genetics, to really begin to unlock that. And that's, if you like, a model. But if we consider cardiovascular disease, of course,
yes,
many studies have been published that look at predictors of poor outcomes or predictors of if patients are going to come back with more symptoms or so on. But they are relatively crude, and they rely on, if you like, Excel spreadsheet statistics. If we really want to go a level deeper and really drill down to the granularity of what brings these things about for particular patients, we need to treat the patients as individuals. And that means looking at all of the data. And when you consider all of the data, there's a lot of it. It's not just their diabetic status, their sex, their age, their body mass index, what their glucose might be. Yes. It'll be how many cigarettes in their lifetime, what their genetics are. It may encompass the use of imaging, so CT scans or X-rays they've had, going back many, many years, and you integrate that with, for example, what we find in the cardiac catheterization laboratory. And one can imagine, cloud analytics that will then give perhaps real-time decision aids to physicians based on comparing that individual patient with many other individuals, locally, nationally, worldwide, to try and see how patients like this one did, rather than just lump them into a big bucket that says patients with angina or patients with coronary heart disease. So that level of analysis of the data is beyond the human mind. It's beyond many computers, but that's where AI really does come in. Think of the number of data points. Think of trying to relate unrelated issues, and that's where the AI machine learning algorithms come in.
Yes, yes. And I mean, the other problem, I suppose, really is that you can come up with a new tech. It's that then how you then integrate all this into a healthcare system, isn't it? I mean, I know you've done a lot of work in imaging, haven't you, around the placing of the stent.
Yep.
And that is very interesting because you can actually I think you can demonstrate. Was it that I think 90% of the time this imaging enabled the stent to be placed in a slightly better position than it would have been otherwise.
No, that's exactly right. You remember that very well. You're right. We have an intracoronary imaging technology called optical coherence tomography, or OCT. Now, in English, what that does, it's a light-based imaging catheter that actually goes into the coronary artery that you use during a stent procedure. And it's been used in many ways historically, but our recent data suggests that if you use it as an adjunct to your intervention, physicians do change their minds about what they were going to do based on just the angiographic appearances in 88% of cases. Now, we've demonstrated that, and we can say, okay, well, physicians change their behavior, and this technology one of our big studies, the Illumian 4 study, we hope is going to show improves outcomes, and those data will be available in a couple of years' time. But going just a bit beyond that, it's not just about how using this can change your mind and how that can change the outcome. It's also about how that fits in more holistically as a therapy. Of course, we're interested in changing physician behavior. Of course, we're interested in changing patient outcomes. But also, we've got to think about all those other pieces that fit into that jigsaw that could really bring about meaningful change. And if we think about that benchmarking, if you like, against other subjects in a cloud-based analytic, you can see how the device could begin to, or the system, if you like, could begin to give real-time decision aid to a physician, which is a bit like having a co-pilot or asking a colleague for advice, find a friend, if you like. And what we're conscious of is that whilst everyone is well trained as physicians, of course, the level of training does vary between people, much like this business of guidelines, as I said to you, that is a one size fits all. Yes. We are aware that the level of understanding and comfort with these technologies does vary a lot between clinicians. So again, going back to that big data piece, the artificial intelligence, in the next release software for this technology, we are incorporating artificial intelligence enabled algorithms to help physicians understand what they're seeing. These algorithms will detect automatically without the need for lots and lots of training to say, when you've used this, this is what you're seeing. And by automating that, we're actually going a step further, saying, if you use the technology, we'll actually tell you what you're seeing. And then potentially in the future, we can then tell you what you should be doing. So this is all about improving the patient outcome and also reducing the variability in the kind of experience a patient will get, if that makes sense.
Yes, it does. So, and I guess there's also the other side of this aspect, which is what happens to the patient after the operation, really, isn't there, and how they recuperate and recover. I must say, I know several men in their 60s who've had stents, and well, they don't actually appear to me to have changed their behaviour very much. They continue much as they were before, and they're not doing an awful lot of exercise. So it's quite interesting to see how people can have this life-changing surgery and then actually not respond much in a way, not feel a need to change their own behaviour.
Yeah, I mean,
a paradox.
This is no, it's a big problem, and it's a big problem. I mean, you can view it as a good thing or a bad thing. I mean, if I think back to my own family, my grandfather was a general practitioner in London before the NHS even existed, and he had a heart attack in the 70s, and at that time, his treatment was to sort of basically have bed rest for 6 weeks, and that was kind of it. And then if I then fast forward to my days as a registrar or fellow in training, of course, we were using clot-busting drugs to treat heart attacks, and patients would stay in hospital maybe a week after their heart attack and have a treadmill test to determine whether they would go home. And now, in the era of the 21st century, in fact, the late 20th century, we moved to what's called primary angioplasty, which is if you have a heart attack, you come straight into hospital and someone unblocks the artery on the spot with a stent. And the problem now is that we've gone from being in hospital for 6 weeks to 1 week, and now these patients often go home at 48 hours. So wow. We're really we're in the process of almost demedicalizing the procedure. So you can understand that if it becomes no more than a trip to the dentist's, people, those kind of advices about lifestyle behavior, which we know are so important in terms of the success of any therapy, may not stick. So I think you highlight something here that we need to be cognizant of, because there are so many things that determine a patient's outcome or the success of a procedure. And some of them relate, of course, to the devices you use and the way you carry out the procedure. But some of them are kind of out with our hands. And rather than just say, well, that's not our problem, we need to be thinking about how we can affect this. And I think one of the ways that we can look at this is trying to engage with patients along their disease continuum or their care continuum. And we're looking at ways that we can engage with patients, how you can make some of those behaviors stick, how you can follow them up. You'll be aware there are many smartphone applications, engagement applications that can not quite do the job of some of the specialists, in this case, cardiac rehabilitation, but really reinforce some of that messaging. And I think that, as I say, in the 21st century, rather than just hope people are going to do what they're told to, there are ways manifestly of encouraging them to prevent them coming back into hospital. And education is a key part of this too.
So effectively, so you're saying that at that end of it, then that there might be an app which Abbott provides, which backed up maybe by some coaching, so you're providing a platform which people could use to deal with these, to increase their chances of rehabilitation. Yeah.
Well, I think we have actually done a pilot in this regard. We did a pilot actually at Papworth Hospital using a patient engagement application for exactly that purpose. And the pilot results were encouraging, looking at ways that we can encourage patients. And this is not a new technology. I'm not going to say we haven't invented this. There are plenty of these platforms that have been out there. In fact, some of them have been out there quite a long time. There was a US-based one, which was probably ahead of its time, maybe 10, 15 years ago. But it's another way that we need to think outside of the box, if you like. So we are trying to not just think about the stent, the device. We're much more thinking about how we can actually modify the entire patient journey. And if that includes thinking of some way of engaging with the patient before, during, and after their procedure, so we can help to maximize the chances of success for that patient, improve their outcome, which, as I've already said, if we put the patient at the center of everything, it's better for the patient because they are actually the end customer. It's not really the physician and it's not really the healthcare system. The patient is actually the customer. He's the one who, if you went to a car dealership and parted with however many £1,000 on the premise of getting a car and you left without a BMW, you're going to be a bit disappointed. The patient is the one who goes home with the stent at the end of the day, not the physician. So that we've got to view the patient as
true, isn't it? Who is the customer is always a good question. It's like that in education as well, isn't it? I mean, I think in a state education system, the customer is the state, and in the private education system, the customer is the parents. But actually, the customer is the pupil. I mean, you can apply that there as well, can't you?
No, I think that's fair. But I think the point of it is that we've got to do things for patient benefit, and I think that we need to shift our focus to: is this technology, is this therapy, does this provide a solution for a problem for that patient? And if it does, it will work for everything. It will improve things for physicians who are pushed for time, etc., and they don't want patients coming back and they want good results. And it will thereby improve things for healthcare systems. And we want to be viewed as the kind of partner that has that vision and can enable that kind of care for any healthcare system's patients to drive improvements across the board.
So it also means we're talking about a huge cultural change within Abbott itself, aren't you, really? I mean, you're going from selling a very technical product specifically to doctors to something which is much broader and which is more holistic, and therefore you need to engage not just with the doctor but with the future strategy plans, I suppose, of the department or indeed the hospital. So that again changes a lot, doesn't it? It changes your relationships in a sense.
I think it does and it doesn't. And I'm just going to bring in some other data from that survey I mentioned, the Beyond Intervention survey. I mean, we interviewed a large amount of patients, physicians, and administrators worldwide, and the results are surprisingly congruent in that all those three groups believe that data and novel technologies have the potential to transform healthcare. Now, that is not a surprise, but it is good to hear that everyone thinks there is a benefit to this. We heard that patients understand that sharing their data will improve things for them and for others, although there are obviously some concerns about data security and so on. But it is interesting to see that both physicians and administrators really see the value in streamlining pathways, in making things more efficient, and obviously improving things for the patient. So I think this is a 21st century solution. It is a culture change. We've got to think about therapies and solutions rather than the device or those individual episodes where a patient happens to come across a healthcare provider. And I think that we hope this vision resonates with people who've read the white paper and who are listening today.
Yes. Well, it's very interesting. We had a session yesterday, actually, on medtech and services, in which we asked we had Martin Brunninger, who's Director General of Austria's health and social care system. And he was saying, if you go into an operating theatre, there are, I think it was 45 different dashboards, all from different manufacturers, or many from different manufacturers. So you compare that to a pilot. And it was very interesting hearing a customer really expressing that same, some of those concerns, I thought. So we're moving in this direction. So when are we going to see this platform from Abbott then? I mean, what's the launch date, Nick?
Well, I would love to say it's going to be here tomorrow, but of course, whilst we are moving towards something that is a more holistic solution, I think to think it'll be a platform anytime, a single platform anytime soon is optimistic. Let me put it that way.
Yes.
But I would say that if we look at the ways that we are trying to interact on that patient journey from first presentation, development of risk factors, right the way through their intervention or interventions and into the follow-up and rehabilitation phase, we have lots of projects at the moment. And as you can imagine, there's not a magic bullet. We suddenly, turn a switch and everything is sorted out. We're looking at ways we can meaningfully interact on that patient pathway. And then we're in the process of joining the dots. And one of the first pieces in that jigsaw, as I mentioned earlier on, is a novel software platform for our imaging technology, optical coherence tomography, or OCT. That will be with us next year. And that includes those artificial intelligence enabled feature detection algorithms, which we think will be a massive step forward. But that's not the only development. I mean, alongside that, we are also, the other developments we have, we're aware that one of the barriers to the use of this technology, of course, is training. In the COVID-19 pandemic, things have been very tricky. We've just introduced a novel way.
Yes, gosh.
We've introduced a novel way of training physicians via virtual reality headsets. So this is very 21st century. We've used a platform technology that's been used in gaming, which enables physicians to train without having to do what I did when I trained, which was the NHS adage of see one, do one, teach one, which probably any patients out there will be rather frightened by that concept, but that's really the apprentice way of training. Using virtual reality and that kind of technology enables physicians to go in and get familiar with a novel technology without having to try it out. I mean, would you get on an aeroplane with a pilot who's never been in a flight simulator? Of course you wouldn't. So that's a direct analogy. So we have those two developments. We've also developed a novel solution for patients with what we call critical limb ischemia. That's foot ulceration. It's a novel device that opens up the blood vessels and then is fully resorbed in a couple of years. And that's a revolutionary piece in the management of these patients with critical limb ischemia. And finally, I want to point out another technology that we're folding into the platform, if you like, which is for measuring something we call microvascular dysfunction, which is rather than furring up in the big arteries, which get fixed with stents and bypass surgery, patients can have disease in the very small arteries you can't see. And that's a very important thing because it has a huge healthcare burden. Patients with microvascular dysfunction and microvascular angina, they keep coming back to hospital emergency rooms. They keep coming back to clinics. They have multiple investigations over years and years and years without a clear therapy. Again, we're folding that in, and that's unique to us.
Yes.
And we're folding that in. So we're looking at different solutions for different things and trying to build those all together and really think about engaging with the patient along their entire, as I say, their disease continuum.
Wow. So that's real change, isn't it? Coming down very fast, actually, really, isn't it?
Yeah, and we've got lots more things next year, which I can't tell you about now, but trust me, they're very exciting.
Yes, so it must be very interesting going from being a doctor to going into a large medtech company. Is it as you imagined it was going to be?
Well, it's very different to a small medtech, that's for sure. The small medtech I worked with was literally a handful of people in a single office. But it's been very exciting. It's been very interesting. It's very different, obviously, to a life as an interventional cardiologist. But I think this is for me, this has been and remains a very exciting opportunity. If I'd have continued NHS practice for another 10, maybe 15 years, if I think about the number of patients I could have treated and reached in that time, it is absolutely dwarfed by the amount of patients that I can potentially affect in this role
and work with in this role.
And so I see my role very much as to be the patient advocate, the physician voice within a large medtech, which, as we've said, is often very focused on devices. If I can just push the agenda of the patient and really make people inside and outside the company understand that we are interested in more than just that single device and thinking much more holistically about patients, if we can leverage data, if we can leverage novel technologies and innovations with the aim of improving outcomes for patients, then everyone's a winner in this.
Your job. And I mean, within all this, I mean, you are also, when you move to that kind of larger platform in which people live longer, happier, well, hopefully happier lives, you are also at some stage going to have to change the payment mechanisms, aren't you? And move away from DRG towards value health outcomes and things like that. I remember talking to a guy from Pfizer, actually, who was trying to sell a chronic disease management solution into the NHS. And eventually, finance director of an NHS trust turned around to him, he said, why do I care if somebody lives another couple of years? What's the financial benefit to my trust of that? And he actually said this, and that's when the guy realized that actually it was really hard selling chronic disease management solutions, which prolonged the life of the patient, to NHS trusts, because they didn't really see the financial logic in a sense. I mean, so that was really interesting to me to hear that anecdote.
Yeah, and you highlight something that I think is very, very important, because if you like, both ends of that sort of paying spectrum, and I would emphasize that, you know, as Chief Medical Officer, I'm medical affairs, and it's like church and state. We are separated from commercial by a very tall wall. But I think one end of the spectrum, as you say, is people don't see the benefit. And the other side of it is that, taking it to its logical extreme or illogical extreme, is if you work in a fee-for-service healthcare system, actually, in some ways, you encourage patients to come back, which makes absolutely no sense whatsoever. So you're implying you want to do a bad job so the patient comes back more frequently, so you can charge them more often. So it does require a bit more thinking about this. And I'm not going to say that we are going to change legislation or policy or anything of that sort of thing. But our attempt in this white paper, which you can find on the Abbott website, is really... It's, if you like, it's a rallying call. It's starting the conversation about this issue. We need to pursue an inward vision of patient centricity and patient-centered and patient-benefiting care. The rest of the world, we hope, will change around us also. We can see many other sort of avenues are changing as we go. And eventually, one would hope this will lead to a conversation about the kind of issues that you described, because it makes no sense for healthcare systems to make money out of patients being chronically unwell, and we should be encouraging health and wellness for everybody, all patients, all people.
Yes,
sorry,
yes, indeed. Okay, fine. Well, thanks very much, Nick. I think that that was very interesting and covers it off nicely. Thanks very much for your time. And that white paper is available, of course, online. It's called Beyond Intervention. I think we've got copies of it as well. So thanks very much. And I look forward to hearing more about the Abbott platform. Okay, thank you.
Thanks very much, Nick. Max, it's been lovely to be with you.
And you. Thank you, Nick.